Well, good morning, everybody, and welcome to the 2025 Heart Valve Society meeting. It's my privilege and honor to be welcoming you this morning, and together with me is Caroline Boutin, who's past president of the Society, and Samir Kapadia, who's the incoming president of the Society. So let me just briefly open with 5 minutes of remarks just to let you update some of you about what's been going on with the Heart Valve Society and where we're at and where we're headed. The Heart Valve Society is now 10 years old this year. This is the list of past presidents and locations of the annual meetings. So you see that it varies from Europe to the US and 1 year in Abu Dhabi, and we're very happy to bring it to Egypt this year. As all of you well know, rheumatic heart disease continues to be the main cause of valve disease in the world. And for us as a global society, it was very important to feel, to listen and to be present in areas where rheumatic valve disease continues to be very prevalent. The mission of the Heart Valve Society is to promote awareness, advance knowledge, and innovate to reduce the burden of heart valve disease with a global and multidisciplinary approach. And I think that is the uniqueness of our society. It's a multidisciplinary society. It's a very collaborative approach that combines basic science, cardiology, imaging, cardiac surgery, structural interventionalists, all of them together around not devices or techniques, but rather the valvular pathologies. And our mission is really to advance that and to continue that collaboration in a global fashion. This meeting includes over 400 participants from 42 different countries. And you can see that there is a global representation from North America, Europe, and Egypt and the Middle East, and Asia as well. So we're very happy with the turnout and the fact that we are pulling from everywhere. Again, this is a very global society, and it's important to hear from every participant around the world. This meeting would not be possible without the sponsor. Our platinum sponsor, Artivion, our gold sponsor, Edwards Life Sciences, our silver sponsor, LeMaitre, our sponsors, AtriCure, CoreSim, and Abbott, our exhibitors, Medividia and Zimmer Biomet. Thank you for the support and for allowing us to host meetings like this one, meetings of the minds that really allow for advancement of practice and science of valvular disease. In the last year, there have been several initiatives that were started in the Heart Valve Society. Some were started before last year, but most were advanced in the past 12 months. These are the highlights of the year: the Journal of the Heart Valve Society, the ISHM standards for reporting valvular disease outcomes, the HVS Education Fund, the HVS Young Professionals Network, and the HVS Website Committee. And I'll just briefly walk you through some of those. This is the Journal of the Heart Valve Society, which after many, many years of trying to find a scientific outlet for all the work that's been done in the society, we finally have our own journal. Our editor-in-chief, Philippe Pibero, who all of you know, has been doing a tremendous job with it. The first issue was published in January of 2025. It is open access. I invite all of you to submit your original research work, your review article, your opinion papers to the Journal of the Heart Valve Society. It obviously is not PubMed listed yet, but I can guarantee you that it will be in a very short period of time. So this is a true highlight of this past year. The ISHM standards for reporting heart valve disease outcomes is a very important initiative that was driven by Hanneke Tackenberg and Emmanuel Lansac, who brought all these scientific societies together, the ACC, the AHA, the ASC, the Heart Valve Society, STS-EX, and others, to agree and on these reporting guidelines reporting guidelines for valvular disease. And I think this is a real step forward in terms of harmonizing and unifying the way that we report outcomes. We don't have multiple definitions on the surgery side, on the catheter side, on this and that. It really is a unified way. It was published simultaneously in all of these journals. And I think this is something that we need to continue to move forward, integrate in the guidelines, and importantly, integrate in all of our research. The HVS Education Fund was an initiative that was started at the behest of our board of directors, and the goal is to support young scholars to attend the annual meeting. I'm happy to report that we had multiple submissions. The decision was very difficult, but we ultimately awarded the travel award to these 3 young professionals, and we're very excited that they were all able to attend the meeting and come. The Heart Valve Society Young Professionals Network was initiated by Caroline Boutin and has been incredibly active in the past year at getting the young professionals together. It's representation from around the world, and there's certainly an invitation for more young professionals to participate. This is not an exclusive club, but rather a very inclusive one. And the goal is really to promote the work of the Heart Valve Society, to increase collaboration and connectivity between young professionals, to allow for job postings and other job opportunities or research opportunities or fellowship opportunities. So these are things that I encourage all of the young people in the room to get involved with. It's a very active group, and it's a very collegial group of people. And finally, the website committee has been steered by Jessica Forcillo and Hector Michelina, who have done an excellent work promoting the Heart Valve Society through a series of interviews online on the Heart Valve Society website, through these weekly journal publications on the topics of valvular disease that are published on the Heart Valve Society website, and many more initiatives that are out there. Again, this is open for all young or established clinicians or researchers who are interested in getting involved. This is a great way to get involved with the society and to have your voice heard. So in essence, the Heart Valve Society is now 10 years old. The Heart Valve Society of the future will continue to build on the legacy of this first decade, with the notion that this is a global society. It's a multidisciplinary society. It is an unbiased society. Our only driver is the pathology rather than the approach. So I invite, again, all of you to continue to be involved. It's the only society that's dedicated to valvular disease, and it's therefore very, very important to continue to let it grow and nurture it. And last but not least, I hope that all of you will be able to join tonight at the reception that will be held at the Grand Egyptian Museum. For those of you who haven't registered yet, the tickets are still available outside for purchase. I would like to highlight the support of Dr. Adams and the Mount Sinai Reconstructive Valve Center for this evening through a very generous donation that supports the entire evening tonight. So thank you for that. And without any further ado, I call the meeting open, and we'll start the first session. I would like to invite the co-moderators to the stage, and we'll get the program going.
Good morning, everybody. We are going to start our first session. And before we start the session, I just want to have some housekeeping remarks. I'm Samir Kapadia from Cleveland Clinic. We are going to have a mic available if you have any questions, because it's an interactive session. So if you have any questions from the audience, feel free to raise your hand, and we will have the mic available for you. We also would like to have, if anybody is not a member of HVS and want to be a member, at the registration desk, we can help. As we said, the educational fund is very important to us, so if you have any contributions that you want to make for that, we are, of course, very open to that. And feel free to visit the Pearl Room and the outside of the hotel, which has a lot of things to look at. With that in mind, we are going to start our plenary session. The first plenary session is on the aortic valve. And I have my co-moderator, Dr. Bavaria, Dr. Ilan Magdi, and Dr. Gandhi with me. And of course, our president. So with the first talk is going to be the lifetime management of aortic valve disease with Dr. Piboro.
Thank you very much. Dear colleagues, dear friends, it's a great pleasure to give this first lecture of the session on lifetime management, which is a very important and timely topic. Gonna go in slideshow mode. Yeah, okay, good. So these are my disclosure. And well, the most important take-home message of this presentation is that the choice of the first intervention, of the first procedure, and the first valve substitute is absolutely key in the lifetime management. This will dictate the whole patient life and care journey. And so there are important decisions to take at the time of this first intervention. Timing of intervention. Is AVR indicated now in this patient? Type of intervention. Should we do a TAVR first, or SAVR, or Ross procedure, or aortic valve repair for patients with AR? And then the type of a valve substitute. So if we decide to go with SAVR, well, should it be a mechanical valve, bioprosthetic valve, stented, stentless, sutureless? And if we go with a TAVR, the choice will be between balloon expandable versus self-expanding. And as for many things in aortic valve replacement, timing is everything. If we intervene too early in the course of the disease, we expose the patient to the unnecessary risk of the procedure itself and of all the complications related to the prosthetic valve. If we intervene too late in the course of the disease, there is a risk of irreversible cardiac damage and associated sequelae for the patient. So the next important step is to decide if AVR is indicated in the patient now. Should we do a SAVR first or TAVR first? And there are some discrepancies in the guidelines between American and European guidelines, as you know, but there are also consensus. If the patient is younger than 65 years old and surgical risk is low, SAVR is definitely the best option. On the other hand, if the patient is older than 75 years old and or has high surgical risk, TAVR is preferred. And the gray zone is more, in patients between 65 and 75 years old, where the American guidelines open the door for both TAVR and SAVR, whereas the European guidelines are more with SAVR in this case. And if you decide to go with TAVR first, well, there are some open issues and challenges for this procedure. Prosthesis-patient mismatch, maybe not the worst one, because as you know, TAVR is associated with a lower risk of severe mismatch and higher residual gradient compared to SAVR, especially in the small annulus. On the other hand, there is, of course, the risk of paravalvular leak with TAVR. That has been the main Achilles heel of the procedure for a long time. Of course, with the new generation, it's much improved, but we still have some mild PVL with TAVR. And then coronary reaccess in the future is an important issue with TAVR. And the risk of permanent pacemaker. That has no impact in the short term, but when you go beyond 5 years, you start to see some impact on mortality and morbidity. And the last but not the least, valve durability. We don't have yet good, robust data for long-term durability of TAVR as we do for SAVR. Another challenge for TAVR is the bicuspid valve. We know from the Notion 2 trial that TAVR is non-inferior to SAVR in patients with tricuspid valve and severe aortic stenosis, but it is inferior for patients with bicuspid valve. Of course, this bicuspid valve harm in the Notion 2 trial was underpowered, so we need more randomized trials on TAVR versus SAVR in bicuspid valve. So this summarizes the factors that favors TAVR as the first option versus SAVR as the first option for lifetime management. Of course, for TAVR, older age, severe frailty, high surgical risk are the key factors. Also, women and or patients with small annulus generally do better with TAVR than with SAVR. Low flow, low gradient as well, for obvious reason. Some anatomical factors such as porcelain aorta, chest radiation, previous cardiac surgery. Transfemoral approach visible is also an argument to favor TAVR. And the last but not the least, very important, patient preference and shared decision making. On the other end, the factors that favor SAVR, younger age, long life expectancy, low surgical risk, these are the key factors. But also the concomitant presence of complex coronary artery disease that needs to be revascularized, or severe concomitant valvular disease, MR, TR, AR. And what we just discussed, patient with bicuspid valve, especially with hostile anatomy, if you have a severely calcified raphe, for example, or if associated with aortopathy. So these are the different strategies that you may consider, you may envision for lifetime management according to life expectancy. And for the patient with long life expectancy at the top of the graph, well, if feasible and done in experienced center by experienced surgeons like Ismail, for example, well, the Ross procedure is definitely a valuable option because long durability and no need for anticoagulation and restore the life expectancy of the patients to that of the normal general population. And then for patients with long life expectancy, you have also SAVR with a mechanical valve. That is a durable option. Not durable in all patients. We know that we have sometimes to explant mechanical valves because of PANUS. And the main disadvantage of mechanical valves is, of course, the lifelong anticoagulation and the associated bleeding risk. And this is probably why, the mechanical valve replacement is going down with time. So the vast majority of the patient will be treated by the biological AVR first. And for patients with long life expectancy, certainly the first intervention should be a SAVR. But we know also that if we do a SAVR in a young patient with long life expectancy, we expose the patient to reintervention, 1 and most likely 2. So we have to assess the risk of a redo surgery of the future and eventually the feasibility and risk of coronary obstruction if we do a TAVR and SAVR procedure. As the life expectancy is going shorter, well, certainly TAVR as the first option becomes a very interesting option. But again, here we have to predict and forecast the feasibility of a redo TAVR, because as we will see, a surgery for explanting the TAVR is not associated with good outcomes. So this is the oops, I think I jumped 2 slides. The outcome of repeat TAVR, what we call TAV in TAV for transcatheter valve dysfunction. So this is from the TVT registry. The 30-day mortality is 6%, stroke 1.8, pacemaker rate 4.2%, which is reasonable. And the 30-day mortality is still much better than what you would get from an explant TAVR strategy with 12.3% 30-day mortality. So what are the implications of a TAVR first pathway? If we decide to go with TAVR first, I think it is important to assess the likelihood and the risk of a reintervention in the future. And if there is substantial risk of reintervention because this is a patient with long life expectancy, I think it is good at the time of the index TAVR to do a virtual CT planning to predict and anticipate the feasibility of a redo TAVR in the procedure in the future. Because if the redo TAVR is likely not feasible, then we have to think twice. Because again, the outcome of an explant TAVR, explanting a TAVR is a complex procedure associated with a 30-day mortality between 13 and 20%, even if this is improving progressively with learning curve. So again, I think it's important to do a virtual CT modeling to assess the feasibility of redo TAVR and also take the opportunity to optimize the index TAVR implant to facilitate an eventual future redo TAVR by using, for example, transcatheter valve with a shorter frame and low valve leaflet hanging. And also make sure that we have a good alignment, commissural coronary alignment. So in the selection of the valve substitute for TAVR or SAVR, I think it is important to balance the proven durability of the valve versus the patient life expectancy. And indeed, the durability clock, the valve durability clock starts ticking as soon as we implant the valve in the patient. And the proven durability for TAVR is 8 to 10 years, if we're optimistic. We have robust data for midterm, 5 to 7, 8 years, and we have some data, reassuring data, for 10-year durability. But 10-year durability means that it is good for patients who have 75, 77 years old at the time of the index procedure. If we want to implant TAVR in younger population, we have to anticipate a reintervention. These are recent data that we obtained from a multi-center real-world registry, suggesting that the risk of structural valve deterioration, defining according to Valkyrie, is higher with balloon expandable versus self-expanding, and this is consistent with other series, and that structural valve deterioration, not surprisingly, is associated with increased risk of heart failure hospitalization, but not of mortality. So, of course, this is not randomized, so this is to be taken with a grain of salt, and certainly we need randomized trial to compare balloon expandable versus self-expanding. So, the factors that favors balloon expandable as the first valve you're going to use for the TAVR, if you decide to go TAVR first, of course, lower risk of paravalvular leak, low risk of pacemaker, the shorter frame, that is an advantage for future coronary access, still a very important issue, and also that facilitate the feasibility of a redo TAVR and makes, if needed, an explant TAVR easier versus self-expanding. On the other end, the self-expanding valve provides better hemodynamics with low risk of severe mismatch and high residual gradient, especially in the small annulus. And as we just saw, they might be associated with a better long-term durability, although this needs to be confirmed. New evidence will change the lifetime management of aortic stenosis. We have now 4 randomized trials, including the early TAVR, recently published, for early aortic valve replacement in asymptomatic severe AS, showing superiority of early intervention in these patients with lower risk of hospitalization and also, in this meta-analysis, lower risk of stroke. And if we go one step further in the future, we also have ongoing trials now of early AVR, early TAVR in patients with moderate AS, at-risk moderate AS, symptomatic moderate AS. But if we, in the future, we decide to intervene earlier and perform AVR in asymptomatic severe AS or symptomatic moderate AS, well, again, the valve durability clock will start ticking even sooner. And we will need now a durability of TAVR of at least 15 years to accommodate this patient. So we raised the bar in terms of durability. And this also opened the role for what I call valve implant-free technologies for the management of moderate AS, and in particular, non-invasive high-intensity ultrasound therapy that is currently being tested in a randomized trial in moderate AS, and also transcatheter mechanical valvuloplasty. It's certainly more invasive, also being tested currently in moderate AS. So in conclusion, well, the choice of the first intervention and first valve substitute is key. The Ross procedural aortic valve repair definitely are a good option in selected patients and experienced centers and with experienced surgeons. The factors to consider when selected this very important first intervention and valve: age, life expectancy, surgical risk, frailty, some important anatomical factors, the anticipated risk of paravalvular leak, severe mismatch, pacemaker, coronary obstruction, the future coronary access, the valve durability versus the life expectancy, and the feasibility and risk of a future reintervention. And we definitely need more RCTs to optimize and advance lifetime management, and the good news is that these RCTs are ongoing. We need TAVR versus SAVR in bicuspid valve disease. We have 2 major trials going to be initiated soon, Believers and Navigate. TAVR, balloon expandable versus self-expanding in severe AS. We have the SMART trial that is only for the small annulus, and the BEST trial that is larger trial, all comers. Early AVR in moderate AS, we have PROGRESS and EXPAND TAVR 2 that are ongoing. TAVR Node has been published. And medical therapy in mild, moderate AS, a less advanced stage of the disease, with a pharmacotherapy trial, for example, LPA, Frontier CVS, and the Valvosoft moderate AS trial. And again, I reemphasize what Ismail mentioned in the introduction. We have now a great journal that has been launched, so please submit your articles. You have the QR code here, and we also have associated with the journal a great podcast series, and you can follow us also. We are on all social medias, so thank you so much. This journal is your journal.
Oh yeah, great. Well, thank you very much. We'll have questions at the end. You can sit down next to our esteemed panel here. Our second lecture will be what will be the role of TAVR in 10 years by Dr. Kapadia from the Cleveland Clinic. And again, we'll stay on time and have a good, robust discussion afterwards. Thank you.
Thank you very much. Thank you for everybody to be here. Good morning. And my job is to... Yeah, I do, because it says it's... You got it? Okay, thank you so much, yeah. Yeah, that's fine. So the talk is what is going to happen in 10 years. So I said we are in Egypt, we at least need to know the history. So I said that in 1500, first time, 1512, Leonardo da Vinci identified the aortic valve. He drew the picture of aortic valve, 1512. It took 150 years. So, if you consider 30 years of 5 generations before aortic stenosis was first described, 150 years. Then it took the first dilatation of the aortic valve was done by invaginating the finger in the aorta to dilate the aortic valve. And a very nice description that Dr. Tafir made. He says that, I feel the thrill when I put my finger there, and I tried to dilate it, but I didn't want to dilate it too much because I didn't know that this is a good experiment to do or not. But the patient survived. Patient survived for 80 years. And then came Dr. Harkin, who did the first aortic valve replacement. I let go the Hufnagel's valve replacement in the descending aorta. But the idea was that it took another, almost, as you see, 300 years since the aortic valve was identified as stenosed, 300 years before we replaced the aortic valve. So 300 years. And now it took another only 40 years to transcatheter aortic valve replacement. So the curve is going exponentially. And if you look at from 89, when first time that Anderson described the aortic valve, he had his valve made, and his father had the aortic valve replacement with TAVR. So again, to say that this is a huge advancement, to say that, and as you would know, a lot of the surgeons that contributed to the aortic valve dilatation, Dr. Smith, for example, had aortic stenosis, and he wanted to have this dilatation with the finger. Ultimately, he died when they tried to do that. So this is a huge accomplishment that his father could have the aortic valve replacement. And then Dr. Cribier did, as you know, in 2002, the first replacement. So we are only 23 years out. So 23 years out from the first aortic valve replacement. So if you can consider Harkin's 1960s like 1992, so or 1985. So it has been a huge accomplishment to have, and Dr. Cribier was a good friend, and we want to acknowledge his contribution to this field. Why this happened? Why this happened is because there was a very systematic approach of studying TAVR. As you can see, one by one, different studies were done, published in very reputable journals, to say that TAVR versus SAVR, early TAVR, all these things. And if you look at the TAVR trials, you can see that we went from very high-risk trials when I was younger to then now to a low-risk trials. And as you can see, the trials with a lot of different, large number of patients enrolled in the trials to systematically study. And thanks to all of you who have participated and contributed to this vast literature. Currently in the United States, not a single tower is done without monitoring the outcomes, meaning that all the towers have to be registered in the TVT registry. So from the first tower till now, all the towers are registered in TVT registry to get reimbursement. So this is how it has been such an important advancement in the field. Of course, the guidelines, as you know, less than 65 currently is surgery, 65 to 80, and again, in European guidelines, that number is 75 years, and 65 to 80, that is equipoise, and then more than 80, a lot of people are undergoing TAVR. This is the current volumes in United States. So if you look at, not current, which 2022, but you see 100,000 TAVRs are done, and if you look at 60,000 surgical AVRs are done, and if you look at isolated surgical AVRs, 17,000. So this is a spread of valve. Now, there are a lot of different data available. I don't know what is the validity of this, but this is particularly from the Vision database published in JACC to say that even less than 65, 47% of them are undergoing TAVR. There is another paper in JAMA Cardiology this year saying that it is about 5%. So I think that is in between, somewhere between 10 to 40% of the people less than 65 are undergoing TAVR. But I think it's more closer to the lesser number than the higher number. But still, a lot of people are using TAVR in the young patient population. Just as you know that the TAVR procedure now is very simple. So this is very important for any procedure, that you take away the expertise. You take away that it is generalizable, that anybody in the small community can do the procedure. This is huge because this allows the therapy to be available to a lot of people, and a real expert is not needed most of the time. This is hard to believe, but this is a reality, that it is a commodity. It's an easier procedure to do. Of course, there are differences in different institutions, but the differences are relatively small. So if you look at simple one groin, you put the device, you deploy the valve, and you check the valve. And then you discharge the same day. This is from Cleveland Clinic, but you discharge the patient at least 30% same day, and rest of them next day. So this is huge to say that a 90-year-old patient with aortic stenosis is going home the next day. This is the reason why most people want TAVR currently. These are our data from Cleveland Clinic to say, again, to point out that these are high-risk patients because we are a very good surgical institution. We work together with surgeons. 4,000 patients, and mortality is 0.4%. So this is huge to say that this kind of people can be discharged at 30 days with 0.4% mortality, with a stroke of 0.5, AR 0.4, new pacemaker 3%. So this is a technology that has made this possible. Of course, these numbers are a little different compared to other institutions. Randomized trials, as you know, there are several randomized trials for low-risk TAVR. And if you look at it, the age is 70s. So don't think that these low-risk trials are of 65 years of age. So this is an important thing to keep in mind. And the follow-up, as you see, is most of them are 1 to 4 years. Only the Notion trial has 10 years, but very small number of patients. And PARTNER 3, 5 years. Now the Evolute has 5-year data too. But this is a meta-analysis. Again, the all-cause death similar. Both groups are very similar. The curves don't cross or anything like that. They are same. The stroke similar. Death and stroke similar. So again, for 5 years, as I said, not all the trials have 5-year follow-up, but still it is promising. This is what people see outside. And so, again, the conclusion that we made was very reasonable to say that, listen, this is a 5-year follow-up, but not all the studies have 5-year follow-up, so new data are necessary for longer-term follow-up is required. So this is a simple idea. I just wrote this editorial to again say that lifetime management, as Philippe mentioned, is very important. And if you're younger, Ross procedure or mechanical valve, critical. So mechanical valve is not a minor thing to keep in mind because it does have very good data and a positive influence on this patient. However, if you're going to look at other things, at every time your priorities change. For example, when you are less than 10 years survival, death is not so important, but stroke may be more important to you. So these are the things that are important to keep in mind, that these are the priorities of the patient versus the doctors also. what will happen in the future? So of course, predicting the future is difficult. So I put these few things. Say that stroke is my passion. So we did the first trial, which was, as you see, that compared to the control group, the CEP was not statistically different. Now there's another trial. We are trying to combine the data and try to understand that what are these, the CEP problem or not. And you'll learn a little bit more in the upcoming meetings to say that the emboli protection works or not. But there are several emboli protection devices, as you see here, that are available and will be available. PVL, very important. So PVL, again, is a problem with TAVR, that there is mild PVL in a lot of patients, and the mild PVL is not without risk. As you saw recently with the trial of a new valve, Accurate Neo, that you could see that the PVL did cause a difference between the valves. So this is, even in the current era, is an issue, and hopefully this will improve with different valve types. There are a lot of AI-related methods to identify that how we can size the valve properly, we can place the valve. So FEOPS, DASI, these are different types of AI mechanisms to have different ways to identify the things. And PVL reduction, as I said, the depth of implant, all these different things that are available. The downside is annular trauma, left bundle branch block, and pacemaker. And as I said, that there are better guards and better techniques available. Pacemaker, implant the valve higher, better, but again, implanting the valve is not always the case, because then if you implant it higher, the valve in valve may not be possible. So these are the things that are important to keep in mind. If you have borderline annulus, meaning that the valves are available in certain sizes, so if you put a larger valve for a borderline annulus, the pacemaker rate is higher, but the hemodynamics may be better. So there is a plus and minus of all the strategies. That is where the expert centers can help you. If you look at the novel considerations, how the conduction system moves, with Dr. Anderson, we did this very exciting study to say how the left bundle branch moves in relation to the membranous septum. What is the angle between the STJ and the annulus? These are all our little research efforts to understand the anatomical considerations for pacemaker implants. Hemodynamics is very important. So if you look at the hemodynamics, we are having two types of hemodynamics. So when you read the literature, you will see something called as a predicted, meaning that you have what a published size of the valve, or measured. And measured has a challenge because now you're measuring it at the annulus. And again, if you look at it, there is severe PPM is associated with bad outcomes. In surgery, that's different compared to transcatheter valves. In surgery, only the predicted one really matters rather than the measured ones. And there are a lot of different reasons why this can be the case, and this is from Harvey Herman, and this is something to keep in mind, and I'll skip this part. Access complications, not trivial. So a lot of people are doing carotid access. There are smaller size valves and the closure devices. Smaller size valves are now 8 French device. So it's like doing a CTO angioplasty. Coronary access is critical, as Philippe mentioned, that there are a lot of different methods now are available, that the THV, and again in the future, there will be commissural alignment already available in a lot of valves that allows a coronary access relatively easily. And the design of the valve and trying to understand the anatomy of the valve is super important, that where we place the valve, how tall is the valve frame, and the valve-in-valve options are also very important, because this is a new vocabulary that you will see, the neo-skirt length, leaflet overhang. These are very important to say that where exactly we can put the valve in relation to the previous valve. So this is also super important, that it is becoming, again, a basic research, and some ex vivo studies are very critical in this development, as we say that we now can go to the low implant valves, we can go to the 4th node, or we can go higher implant, depending on how the anatomy looks. And you can see this a lot of different studies now published to say that what will be the importance of valve-in-valve with different combinations of valves. I just want to highlight this, that the durability of surgical valve literature, we published this several years ago, that there are 11 definitions, 11 different definitions. So this is something to keep in mind, that when you look the literature, FDA approved. These are all FDA submitted data, and there are 11 definitions. We put it in JAMA Cardiology. And very importantly, when you're younger, the biological valves have lesser durability. So again, mechanical valves are something important to consider, Ross procedure, or something similar to that. is an important thing to keep in mind, because when you're younger, the durability of the surgical valve is less. And this is just to say that when you are evaluating the surgical valves, also the core laboratory, routine follow-up, all these things are super important. There are newer methods that you will see, calcification, and as you will see in the next talk, that how the calcification of the aortic valve can be identified earlier, because now we cannot wait for 10 years, because the challenge is that every time a new valve comes out, we say, oh, the old valve was worse, new valve will be better, so all the data are not available for the follow-up or durability. So some method to say that the sodium fluoride uptake, a lot of different ways to say early calcification will be studied. As you learned that bicuspid valve, we need a randomized trial. And these are the trials. So Philip mentioned this. And these are the investigators doing the trial. And the newer aortic valve, the Seagull valve, is already being investigated in the United States. 8 French valve, amazing. Dura valve, single leaflet valve. Sapien X4 available. Jena valve for the aortic regurgitation. So all these are the newer valves that will be available. Dr. Braunwald published this in 1968 to say that once you develop symptoms, you die. We replicated that, unfortunately, in the Partner 1 trial, where everybody died, 179 patients, all of them dead at 5 years, but we replicated this data. Now is the time to see how we can identify aortic stenosis early. And chest X-ray, ECG, AI methods, all are coming in place to say that we can identify. We also investigate this particular device where you just wear like a pulse oximeter and you can identify the problem. Tissue-engineered valves are going to come out, and again, we had a nice session yesterday, basic science-related research to say that a lot of different ways of this is in Nature review coming out. And of course, adjunctive pharmacotherapy, very important. So pharmacotherapy before and after is going to happen in the TAVR, where different types of SGLT2, RAS inhibition, RNA, plus anticoagulation is coming. Staging, as Philip mentioned, is very important, and so I'll skip that. And then upstream management is very important with severe asymptomatic AS, moderate AS that is coming. This is what Philip showed in a different way, but this is happening with different grades. So I'll just conclude that what will happen, we will learn more, that's for sure. And again, this is an organization which is interested in research. Technology will improve, monitoring of aortic valve disease as well as prosthesis may be different and better. Hopefully, the technology will be cheaper, it may be safer, and it may be more durable. And so this is what all I think will happen in 10 years, because 10 years is such a long time. At least I'm going to retire in 10 years for sure. So thank you for your attention.
Thank you so much, Dr. Kapadia. I mean, we'll leave the discussion and the questions to the end of the session. Our next speaker really needs no introduction, Dr. Emmanuel Lansac, and he's going to address long-term outcomes of BAV repair.
No. Yes. Well, okay. Thank you very much. Well, thank you very much, and thank you for the invitation, and congratulations for the organization of the meeting, Ismail. It's my pleasure to discuss about aortic valve repair and what have we learned after 25 years. I do have a disclosure with Cornell, with whom I developed the expandable aortic ring to repair aortic valve. Repairing the aortic valve is actually not a lifetime management, but could be a lifetime treatment. And I think that's very important to have that in mind. And the first question that we should ask is, like for the mitral, can we repair the valve first? And then if we can't repair it, then what is the valve substitute? Because indeed, there are now multicentric trials and the latest meta-analysis showing that valve sparing, root replacement particularly, improve survival and reduce thromboembolic events that there is no increased risk of reoperations compared to mechanical bentals or mechanical valves, and that biobentals increase the risk of reoperation already at 4 years. So this is very important to have that in mind. So first question is, can you repair the valve? Because the problem is that aortic valve repair is still very rarely performed. The latest STS database slides, I took it from Joe Bavaria at the North American Aortic Valve Repair Symposium last year in Philadelphia. And that showed that the rate of valve sparing is only 15%, while bentals are still 85%. And in 2021, it was still 13%. There is a slight increase, but it's still underused. While we know that aortic valve sparing or repair, like for the mitral valve, is the only treatment that could restore normal life expectancy and quality of life, like for the Ross procedure as well. So living valves matter. And we already as well published that 80%, at least 80% of tricuspid and bicuspid valve can be repaired. So the goal is to repair all repairable valves, and that's our mission for the next few years. What is very important first is to understand the difference between valves, tricuspid valve, bicuspid valve, unicuspid valve, and we name it by leaflets, but as a surgical point of view, I think naming them by commissures matter, particularly if we have the objective to repair the valve. Indeed, tricommissural valves have 3 leaflets and 3 interleaflet triangles. Let me have the pointer. And they have 3 interleaflet triangles, 3 commissures. There are 3 commissural valves. And the bicuspid form first, they have a little raphe, but they have 3 functional commissures, so they can be considered as tricuspid-like valves. The bicommissural valves, they have either a raphe or no raphe. We'll look at that in the future, but they have 2 interleaflet triangles, so they are bicommissural valve, and they will be treated as such. And this is very important to differentiate that from unicommissural valves that have 2 raphes and only 1 functional commissure. So when you repair those, you will have to reconstruct 1 commissure. Regarding the bicuspid valve, thanks to the work of Hector Michelena, who coordinates a very important task force to establish a nomenclature and a classification for bicuspid valve. And this is very important work. A lot of people participate into that. And what is very important is that was mentioned to first identify the phenotypes, either normal roots, dilated roots, ascending aorta phenotypes, or the extended phenotypes, and this helps to first identify the phenotype of the aorta, and then, of course, the different types of bicuspids, with either fused raphe, 2 symmetrical sinuses, or the form first, which are very important to recognize as well, which can be the tricuspid-like. And indeed, as this was very nicely described, there is an anatomical spectrum starting from the partial fusion of the, I don't know if you, the partial fusion on the, here on the, on this side of the form first, going towards here, all the different spectrum and the different types of bicuspid, from very asymmetric to symmetric, and 2 sinuses. So all the bicuspids with this difference of the very asymmetric valve will be considered a bicuspid valve repair. So they are bicommissural. We'll treat them and we'll go through that in details how we manage that, but they will be bicuspid valve repair. And the tricuspid valve of the form first and the very asymmetric might be treated as a tricuspid aortic valve repair strategy with 3 commissures. So we'll go that into details. Because there is still a debate among the surgical strategy on symmetric or asymmetric reconstructions, With symmetrical valve, we can keep them at 180 degree. Rather asymmetric, not too asymmetric, we can keep them at 180 degree. The very asymmetric, they were the options described by Joe Bavaria, the Penn School on 150 and 210 configuration, and the other type of asymmetry to bring them into 180 degree. And there is some discussions whether we should deal it, respect the type of the valve and the position of the commissure, or should we put them at 180 degree. An important work was brought by Jochen Schaefers in that matter, which showed that commissure orientation matter in terms of valve stability. Not the original configuration of the commissure, but the way we address it. And this is very important because this slide has been interpreted that bicuspid valve with less than 160 degree are at risk factor. This is not the case. This is the repair when we keep an angle less than 160 degree is a risk factor for reoperation, while if we put the valve more symmetric, we will have a better valve stability. And we also published in 2023 that symmetrical design reduced the transvalvular gradients as well as the intercommissural angle of the bicuspids. Asymmetric bicuspid was not a risk factor of reoperation as soon as we have a symmetrical design of the repair. So that's one of the first important lessons. So now if we go into the surgical strategy stepwise, one of the first things is first to identify retraction. The geometric height should be measured on the non-fused cusp, and we want to have that geometric height less than 20 millimeter. If we have less than this, particularly the rheumatic, we can have rheumatic on bicuspid valve, we'll have a retraction, and they are you might decide to change for replacement. Then the important part is to line up the free edges of the cusp. That's the first important step when you do any kind of repair, either valve sparing or an isolated aortic valve repair, is that you will line up the free edges of the cusp, and your reference cusp is the non-fused cusp. And this is a very important parameter. And then what you will have to do is to adjust the commissure to 180 degree. So this can be performed either with, can you, oh, I can't click. Oh, okay, very good. So either you can do an AMI remodeling complete with 2 symmetrical sinus, or an AMI remodeling with 1 sinus. So you will cut the graft into 2 symmetrical tongue, and this will help the valve to follow the graft and place the commissure at 180 degree when you have to do a valve sparing root replacement or an AMI remodeling when you just replace the ascending aorta. With the non-coronary sinus, this will help you to position the valve symmetrically. This is very easy. The valve will follow the graft and the commissure will be automatically at 180 degrees. That's the first option. When you don't have to do a valve sparing root replacement, when you will do a root preserving surgery with the valve repair, then you will you will restore the ratio between the sinotubular junction and the annulus by an STJ ring that could be placed at placing the commissure at 180 degree. And this will be very important because this will resize the STJ, which is proportionally to the annulus dilated as well. And this will be, in this case, combined, if the valve is asymmetric, with application of the sinus in between the commissure, between the right and at the left, at the level of the raphe. This has been documented by Jochen Schäfer's work as well, in order to decrease the, improve the symmetry of the valve and the commissural orientation by associating the plication of the sinus and the STJ ring. Then we have to manage with the effector fight. This is also a very important parameter that was brought by Jochen Schäfer a very long time ago. For tricuspid valve, we know that effector fight, normal effector fight is around 9 millimeter. This should be measured on the non-fused cusp. But what you want to have is to preserve as much as possible the length of the non-fused cusp, because this will be your opening of the valve for the long term. Like after mitral valve repair, the anterior mitral leaflet will be the opening long term. This opening will be done by the non-fused cusp. And you see that if you are aggressive into the resuspension of the non-fused cusp, you have to add an extra stitch on the fused cusp, and this will lead to limiting the opening and potential reduce your valve opening for the long term. We also know that pericardium is an issue. Cusp recontractions with a substitute is an issue, and the ideal valve substitute is not there yet. So when patch repair is considered, particularly if it's a large patch, then you may want to consider for the Ross procedure. Another important parameter is, of course, the dilation of the annulus, which has been described since many years being a risk factor for different sizes, 25 millimeter or 28 millimeter. But there have been numerous studies showing that circumferential annuloplasty improve the results, that subcommissural annuloplasties do worse because they are not complete circumferential annuloplasty, and that the annulus is a risk factor for reoperations. So this is also a key parameter for bicuspid aortic valve repair. And in that regard, the latest publications on the reimplantation techniques, which is one of the techniques that is recommended to be aggressive on bicuspid repair for any type of valve, even with non-dilated roots, improve the stability of the repair with a 99% freedom from reoperation at 10 years. What also matters is the sinotubular junction. So the sinotubular junction, and particularly restoring the ratio between the sinotubular junction and the annulus, is also a key parameter. And this has been documented already in isolated repair, either tricuspid or bicuspid valve since 2020. But in this recent 2023 paper, we looked at the data outcomes after bicuspid repair using either single annuloplasty without STJ ring, or double annuloplasties, or supracoronary aorta with annuloplasty, or remodeling with annuloplasty. And there is a difference. When you restore the ratio between the sinotubular junction and the annulus, there is less than 3% reoperation at 9 years, while there is 22% reoperations when you do a single annuloplasty at a subvalvular level. So restoring the ratio matters. So what did we learn on aortic valve repair? And to summarize, first, you want to align the free edges of the cusp on the non-fused cusp and place the commissure at 180 degrees. This is the basic principle. So in other words, to be simple, you want to transform any type of bicuspid into a symmetrical one, and you want to preserve the free edge length of that non-fused cusp for long-term opening. Then you need to treat the diameter. The annulus, so do a subvalvular annuloplasty. The STJ, either with an STJ ring or a tube graft, and preserve the root dynamics by either do a root-preserving surgery or valve-sparing root replacement with neosinuses of Valsalva and try to preserve as much as possible root expansibility and dynamics of the roots. Then you adapt your strategy to the patient's phenotype and to the ascending aorta phenotype as it has been described in the classification, the international classification of bicuspid. Either you have a normal root and you can do a double annuloplasty with plication of the sinus, or you do an AMI remodeling with an open annuloplasty, or if you have a valve sparing to do, you do a remodeling with annuloplasty or reimplantation procedure, placing the commissure at 180 degrees, and therefore you can achieve good, stable, long-term durability of your bicuspid valve repair. Thank you very much for your attention.
Thank you, Emmanuel. This was an excellent review. Next up is Jordan Miller, who will talk to us about aortic valve calcification. Can it be modulated? And Jordan.
Yes.
Okay. Very good. Thank you. Okay, thank you very much. So the biggest question here being with aortic valve calcification, can it be actually meaningfully and safely slowed? And so what I'd like to present to you today is some of the work we've done over the past decade plus on really barriers and opportunities in translation, discovery, and application. And so here's conflicts. So I think over the last number of minutes here, we've actually seen some of the current clinical paradigms in standard of care. Patients undergo watchful waiting. We've got indirect or palliative treatment modalities currently for patients with aortic valve stenosis. Or ultimately, it's moving on to surgical intervention. And so I won't be using that because I'm really ineffective at pointing this. But collectively this leaves patients and providers with a substantive gap in treatment opportunities for valve calcification and progression of aortic valve stenosis. And so our overarching goals over the past decade plus have been to really identify mechanisms that contribute to valve calcification and identify novel therapeutics that are well tolerated that ultimately can slow progression of heart valve disease. And so when we're looking at our current treatment paradigms, patients are typically identified with moderate aortic valve stenosis, mild to moderate aortic valve stenosis, and then undergo an extended period of time with watchful waiting, and that ultimately results in over 182,000 procedures, valve replacement procedures in the United States alone. And so huge clinical gap here and gap for patients and providers. Now, when we look at our current biological paradigms in cardiovascular calcification and aortic valve calcification in particular, we've got actually a large number of models and mechanisms that have been identified over the past several years that have really advanced our understanding of mechanisms that may be contributing to disease progression. And if we were going to summarize these in terms of some overlapping themes, we know that inflammation is strongly associated, valvular inflammation is associated with valve calcification disease. We know that there's some lipid component in a subset of patients that contributes to disease initiation and progression. Certainly at its core, there seems to be osteogenic signaling that's promoting valvular calcification, ultimately making that a very attractive mechanism for targeting therapeutically. And then we've got these mechanical factors, both systemic and microenvironmental, and a relatively large number of other modulators of disease that might be more difficult to target therapeutically. And so for us, our overarching goal, again, is after these patients are identified with progressive aortic valve stenosis, we really wanted to work to identify safe and effective pharmacological interventions that can delay or even halt progression to intervention. And I think even as we look at some of the sessions earlier today, the question being is, what's the first intervention? Ideally, what we want is we want a first intervention that's going to be slowing progression of valvular calcification and delaying that time to first intervention, perhaps even converting to a once-in-a-lifetime intervention. So for the rest of my talk this morning, I'll just go over our efforts to advance a drug for treatment of aortic valve calcification and stenosis, really using this as a platform and template for future efforts to identify the therapeutic utility of other mechanisms that might be contributing to valvular calcification and stenosis. And then also as a field and as a society, where are our opportunities to contribute meaningfully to this domain and moving forward. So for us, we've really taken a laser focus on osteogenic drivers of cardiovascular calcification. We've known for decades now that there's robust induction of this molecule called bone morphogenetic protein signaling in calcifying blood vessels and certainly in calcifying valves. And so again, this provides us with a really nice platform where we could say, well, if we can modulate that in an effective way, we should be able to slow progression of valvular calcification. And this has really been a ubiquitous finding in our model systems and in human tissues. And so whether we're looking at genetic laboratory or pharmacological or clinical evidence that would suggest that this can result in valvular calcification and if theoretically modulated could slow progression of disease. It's a really exciting area and mechanism to try to focus on. The challenge with targeting it is that bone morphogenetic protein signaling does a lot throughout the body, and so targeting it directly, much like many of the mechanisms that were highlighted previously, is really a therapeutic non-starter. And so that leaves us with targeting some of the modulators of bone morphogenetic protein signaling and some of these other signaling cascades, and trying to leverage that for therapeutic efficacy. And so in particular for us, we've taken a significant focus on nitric oxide signaling. And so we know that nitric oxide is produced by endothelium, certainly vascular endothelium, valvular endothelium, and that after it is produced, it diffuses to valve interstitial cells, binds to a receptor called soluble guanylate cyclase, and that elicits a cascade of events that ultimately is cardiovascular protective. And so it's a really very attractive approach to try to attack a number of diseases, including valvular calcification. But again, it's not without its limitations. So targeting nitric oxide signaling systemically is also therapeutically very challenging because it has profound effects on blood pressure. And so there you really need to have an approach that allows the targeting of this in an ideally in a relatively local way. And so what we ended up having was, I would say, serendipitous access to what we think is the right drug for modulating nitric oxide signaling and valvular calcification, and that drug is called atosiguat. It was a novel chemical entity that was terminated in development by Sanofi due to a lack of efficacy signals in other diseases. And there they felt it was a selective activator of oxidized soluble guanylate cyclase. And so essentially what happens is when you have high levels of oxidative stress, that receptor gets oxidized, and atosiguat is able to reactivate that really only in diseased tissues. And so for us, it was really fortunate because there was a significant safety database that allowed us to move forward with confidence pretty quickly, and then our funding with the National Institutes of Health to move through preclinical phase 1 and phase 2 trials. And so what I'll run through here is just some of our sort of legs of the stool here when we're looking at our preclinical strategies. Again, looking at human tissue, saying are these pathways able to be restored? Biochemically, how do we confirm how atosiguat worked? And then moving through in vitro and in vivo studies just really quickly with a sort of unapologetic translational approach, view of taking this forward. And so When we're looking at end-stage tissue from patients with end-stage aortic valve stenosis, we know actually that this is phosphovascular 239, so it's a downstream biological readout of nitric oxide signaling. So that is significantly reduced in valve tissue from patients with aortic valve stenosis. So we have that loss in nitric oxide signaling in the valve, and we've known for a number of years from work from Nalini, Rajman, and others that nitric oxide, endothelial nitric oxide expression is reduced in valve tissue itself as well. So really demonstrating that the pathway that we think is important is lost in valve disease. But importantly, the receptor for nitric oxide, so for soluble guanylate cyclase in particular, all of its subunits are actually significantly increased in the valve. And so we think that's actually compensatory because we're losing nitric oxide production, and then we're getting upregulation of the and sensitization of the receptor in those tissues, which for us, whether we're looking at the alpha or beta subunits, because it's a heterodimer, that actually gives us a lot of substrate for this drug to bind to, and a really exciting opportunity for us to deliver something that we might think is therapeutically viable. And so from 50,000 feet, right, soluble guanylate cyclase signaling and nitric oxide signaling is reduced in valve tissue from patients with end-stage disease, but we get this nice paradoxical upregulation of something that we think is going to be a therapeutic target. Now, we went on to then say, well, how does atosquat really work mechanistically and biochemically? What we found is that when we're looking at reduced SGC, which is the healthy form of soluble guanylate cyclase, and systemically what allows for vasodilation, that's actually really not, atosquat doesn't really effectively induce the activity of reduced soluble guanylate cyclase. But when we have heme-free or oxidized soluble guanylate cyclase, what we get is a much more robust engagement of the enzyme, which really strongly suggests that atosquat might actually be activating this pathway preferentially in diseased tissues. And so when we start to look at mechanistically how this would work and whether this would work in valve interstitial cells, we use isolated mouse aortic valve interstitial cells, again using phosphovascular serine 239 as that readout for nitric oxide signaling. And you can see that in male mouse cells, we get significant induction of soluble guanylate cyclase at our highest two doses, both of which are therapeutically relevant. Interestingly, we see a little bit less activation in female mouse cells. But then reciprocally, when we look at osteogenic signaling and bone morphogenetic protein targeted mRNA levels in particular, like Ostrix, what we see is a significant reduction and dose-dependent reduction in bone morphogenetic protein signaling in these valve interstitial cells. And so, again, just proof of concept that if we restore nitric oxide signaling, we can suppress what we think is a major driving pathway of valve calcification and stenosis. So from there, we jump to our mouse model of aortic valve stenosis. So here it's a little bit complicated. It's a double knockout mouse. It's a low-density lipoprotein receptor deficient apolipoprotein B100 only mouse. If you say that a lot of times in talks, it sort of rolls off the tongue. But in brief, this has been what we found is one of the only animal models that actually develops significant gradients across the valve and hemodynamically significant valvular stenosis. And our approach here was to either feed these mice a Western diet for 9 months or a Western diet for 6 months, followed by 3 months of treatment with atosquat in moderate valve disease, and then explore whether we could actually significantly slow progression of valve disease in this established disease. So again, when we're looking at phosphovascular serine 239, we're actually getting, when we treat with atosquat, we significantly activate nitric oxide signaling in the valve tissue itself. When we look at phospho-SMAD 158, which is canonical bone morphogenetic protein signaling, again, atosquat significantly reduces bone morphogenetic protein signaling in the valve tissue itself of these mice. When we look at valve calcification, again, now we're seeing nice reductions in valve calcification in these mice, significant reductions in both males and females. And then when we're looking at valve function with cuff separation distance and high-resolution echocardiography, we see actually in male mice, we see a significant preservation of valvular function. And interestingly, in female mice, we don't see that much of an effect there, which is consistent with some of the emerging data that valve calcification might be a major driver of dysfunction in males, maybe a slightly lesser role in females. So collectively, from a preclinical perspective, we see that atostigouat significantly increases soluble guanylate cyclase signaling in cells and animals, reduces bone morphogenetic protein signaling, that key driver of valvular calcification from a molecular perspective. It attenuates valve calcification in vivo, and then also slows progression of valvular dysfunction in mice in vivo. And so from there, with the funding mechanism that we had, we were really charged with moving quickly towards phase 1 and phase 2 trials. I won't show you the phase 1 data because negative phase 1 data is usually the best kind of data. Atostigouat didn't impact blood pressure. It was very well tolerated. And so we were subsequently endorsed to move forward to a phase 2 trial, which had a primary outcome variable of the change in aortic valve calcification by multi-slice CT, secondary outcome variable of changes in valve function by echo, and tertiary outcome variables of changes in left ventricular function. And so our primary outcome here being changes in aortic valve calcification, and so we were really excited to see it roughly in patients that were treated with atostigouat for 6 months. In a randomized double-blind placebo-controlled trial, we see about a 70% reduction in progression of valvular calcification compared to placebo. We see parallel changes in valve function, again, about a 50% reduction in progression of valvular dysfunction. And importantly, and as alluded to in some of our previous sessions, we saw a relative preservation of changes in ejection fraction, which, again, we don't make a mountain out of a molehill here, but we do feel that even with relatively short-term follow-up here, showing any sort of tendency was really attractive. Furthermore, we saw tendencies towards preservation of diastolic function in these patients. And so, again, if we look at an interim summary here, when we treat patients with atostigouat for 6 months, this is the first trial, that randomized double-blind placebo-controlled trial, actually showing some degree of efficacy for preservation of valvular prevention of progression of valve calcification, preservation of valve dysfunction, and preservation of left ventricular function. And this is now moving forward into a phase 3 trial. And so, I think as alluded to in some of these other talks, there are a lot of things that we could do differently, could do better, including some advanced imaging techniques that could allow for identification of early biomarkers of efficacy, as well as more sensitive ways to assess, multimodality ways to assess progression of valve disease. But I think as a society, what we really can look towards is saying what's on the horizon and what data are actually needed to enable approval, patient engagement, long-term adherence, and value to payers. And so I took this from the ISHOM publication that recently came out in the Journal of the Heart Valve Society, where I think there's a huge opportunity for the Heart Valve Society to create a parallel path that will help inform pivotal trials or phase 4 trials for drugs for aortic valve stenosis. And in particular, I think this left half of the circle is what will likely change most, where we'd be looking more towards drug-specific and drug-not-specific outcomes, including side effects and unexpected adverse events. But I think equally as importantly, providing that granular guidance on the right half with patient-centered outcomes that will enable demonstration of value across the board, including quality of life and functional capacity. And so, again, I think there's a lot of promise with a lot of therapeutic opportunities. There are some barriers here, right? We want to make sure that whether we're targeting, inflammation, that we're not increasing sepsis risk, that we identify the right time for intervention, that we don't negatively impact bone ossification, things like that. But again, I think that there's a huge opportunity here for the Heart Valve Society to play a significant role in this field. And so, we've had a very large collaborative team that's enabled us to move this forward. And with that, I thank you for the opportunity to present and look forward to the discussion at the end.
Thank you very much. Our last speaker will be Dr. Boutin, Professor Boutin, I should say. Tissue engineering of aortic valves. Will it always be in the future or not?
The next one. The next one.
I think we'll give ourselves an extra 5 minutes for the discussion, so we'll go a little bit past 10:30 since we started 5 or 6 minutes late. At the pleasure of the president.
Thank you so much. Thank you for the introduction.
You have to hold to press
Yeah?
the point on the screen.
Good, works. This is my disclosure. Thank you for giving me this thought-provocative title, Aortic Heart Valve Tissue Engineering. Will it always be the future? And I imagine this title came up because tissue engineering is no longer a new kid on the block. It was started 20 years ago already, but it's still not in the clinic. So will it remain an academic exercise, or are we really moving to the clinic? And the short answer is yes, and I'll show you how. So heart valve tissue engineering was started to create living autologous valves to cope with some of the durability issues of current prostheses, also coagulation problems of current prostheses. And it actually consists of a procedure where you isolate cells from a patient, you put them on a carrier, a scaffold that is degradable, then you culture a valve in the laboratory and you implant it in the patient. Now, patients so far are large animals, mainly sheep, goats, etc. So the beauty of this is that you can also, except from preventing durability issues, because these valves should last for a lifetime, also cope with the growth and remodeling of living valves. As you can see here on the left, these valve leaflets grow throughout lifetime. So the procedure is particularly interesting for young patients that require lifelong solutions. But this procedure is expensive, complex, and cannot cater to many patients because we need sophisticated laboratories to create such valves. So the whole field moved, together we moved to a procedure, let's see if my movies work, they did, my apologies, where valves are grown inside the body. We call this in situ tissue engineering. It's good to see the movie, where you actually implant a cell-free device, a valve, that inside the body degrades, but at the same time recruits cells from the bloodstream that create new tissue, attracts other cells, and while new tissue is being formed, the scaffold is degraded, leaving behind a living valve. And of course, this is less expensive. It also creates less problems, less complexity in the laboratory, but it requires a lot of the design of the scaffolds. The novelty of the approach is that we, like with all the guidelines or ICHON, we move from a device-centered approach to a patient-centered approach because we implant the device, but the patients themselves are creating their own valves, and it's completely autologous. Now, next to the reduced costs of the laboratory procedure, Hanneke Takkenberg and her team calculated some years ago with us that this is also a very cost-effective procedure because next to an increase in quality of lifetime years, the cost of the procedures are lower because people do not need reoperations, go to clinics less often, etc. Now let me show you how we design such a valve. We start with designing a material that can degrade, but can also be decorated with biomolecules to attract cells, are porous to recruit cells inside, and that can also be filled with fibrin in the bloodstream to not leak. In laboratories, we can study how cells and tissue be formed in those scaffolds, which we can test, of course. We can do predictive modeling, computational modeling, very strong aspect of this work, so you don't need to do a lot of experimentation in vivo. And then when we have a good material, we can test it in small animal studies and larger animals. And of course, we can redo this cycle. And several groups around the world are doing this to come to a in situ strategy to test in vivo. And this is the current state of the art. There are several approaches. In our team, we work with degradable polymer scaffolds, but here are some examples. This is the Aspire clinical trial where people work with decellularized homografts. Of course, you need tissue for that and homografts, but they take the cells out, implant the tissue, and inside the body, a new tissue can be formed with those natural scaffolds. Then there is a strategy where people grow valves inside the laboratory, in vitro, like I showed you earlier. They take out the cells, so there is no immune response inside a recipient, the host. And with this blueprint, this natural extracellular matrix scaffold that's produced by the cells, a new tissue can be grown inside the body. This is all for pulmonary valves and all tested in vivo. And this is an example which was shown to us yesterday by the Vasculine team and the team of Bob Tranquillo. They also work with desorized scaffolds, fibrin-based, and are also doing preclinical trials at the moment. Now, in our team, we worked with synthetic materials, so you can get them from the shelf, make them in different sizes, decorate them with molecules, etc. And this is being translated to the clinic with the company Celtis. So you see in red, I've indicated several companies, startup companies working in this area. And finally, this was also shown yesterday by the team of Professor Jakub, also a polymer valve, but in this case a conduit, a valved conduit, also implanted in the pulmonary position. And here I made a mistake. I thought it was published in 2021, but it was 2023. So this is the state-of-the-art of in situ heart valve tissue engineering, but for the pulmonary side. Now we're slowly moving towards the aortic side, and we started, of course, here because the hemodynamics are not that challenging, and the hemodynamics are really important, and I will show you later. So what makes it so complex? Why is the translation going not as fast as you would like us to move? First of all, we're working with small teams, limited budgets, no big industry, but very, very dedicated. So sometimes people ask us, has it failed? Are you not progressing? But yes, we are. You could have seen that yesterday during the ICTAF pre-symposium. But what makes the procedure very difficult is that we are implanting a device, but the patient makes his or her own valve. And the immune system of the patient is the first to attack our materials. We make use of it, we harness it, but of course you need to know how this works. And this steers the early weeks, but also the late tissue outcomes. So the clinical trials, preclinical trials I showed you, all work with studies that go up to 1 year to 18 months. Inside the body, the tissue remodels, and the remodeling, of course, is influenced by hemodynamic loading. And in the end, when the scaffold is degraded, we really need to have a nice homeostatic tissue. Now, this early host response, we first have an inflammatory response to the material, which everyone will have in the body, but this can be skewed by earlier diseases or earlier inflammations or comorbidities. And this makes it so important that we have immunologists, biologists, and clinicians in our teams to work with us. Now, hemodynamics, I told you, it's extremely important, but also the design we have for the materials. So people often think we should copy the blueprint of nature and really make this. So we did it. We made anisotropic valve leaflets, similar to native valve leaflets. You show it here on the bottom. We made anisotropic valves, so this is the microstructure. We create our valves with electrospinning, very fibrous structures. We also made homogeneous isotropic valves without a preferred direction. And the idea is that a natural blueprint or anisotropic valve would function better inside the body. Now the opposite was true. When we implanted the natural blueprint of the valve, what we saw is the body remodels our tissues immediately. Like in the immune system, the body takes over. And the patient is very important here. And in the body, the mechanical properties or anisotropy of the tissue was immediately taken over and disappeared after 1 month already. Now, after a whole year, the anisotropic valves, and here you see them in red, performed better. So the natural blueprint eventually performed better, but not because of the mechanical and structural anisotropy, but because the scaffold was degraded quicker. If you have aligned scaffolds, immune cells invade quicker and degrade the scaffold earlier. So the body is really something we need to understand in this design. Now, where do we stand in my team in Eindhoven? We created electrospun pulmonary valves and planted these in large animals. I did it together with a group of Jolanda Kluin, and we showed that we have functional pulmonary valves we tested them up to 12 months. Beautiful valves. We could also transfer this technology to a transcatheter approach, which was also very functional. We did it in collaboration with the Zurich team of Simon Hurstrup and Max Emmert. And then it took us 6-7 years to move to the aortic valve. Again, because the technique is not so complex, but the body in which we implant and the hemodynamics in which we implant the system is complex. So last year we published the first application on the aortic side, also with a follow-up of 1 year. All valves remained functional, but we saw some very interesting discrepancies in tissue formation and very different from the pulmonary side. So here you see an example of the leaflets. So this is a leaflet, and this is the part where we attach our material to a stent. The stent was needed because we have tissue formation and real growth inside the body, and you need to do that in this very symmetric way. So working with a conduit is less ideal than working with a stent that keeps the valves in a symmetric position. And then we cultured the leaflets. Oh, sorry, I showed you the leaflets here. And we have beautiful thin leaflets, good histology. All valves were thin and pliable and very functional. But if you look at sorry, this is going too quick. Now I lost all my slides, not sure what's happening here. I can do this quickly, don't worry. If you dive into I can do this, don't worry. Here is the slide. Should be okay, right? Don't know what happened. Yeah. So we had about 70% good valves, nicely covered with endothelium, but with limited cells inside the tissue. And we believe the harsh hemodynamics do kill the cells that we either recruit in the tissue or the material, or we cannot recruit them because of the harsh hemodynamics. We had a small portion of cells that were really full of cells, living cells recruited from the bloodstream. Here you see all these black dots. And we had a portion of valves which were not showing nice tissue formation. They were a little bit fibrotic, thickening, etc. This is what we want to analyze further. So we have good success with a small portion and limited success. But what was most interesting in the valves that were not fully populated with cells, here you see those leaflets, the material does also not degrade. You see it on the right side. These are the fibers. They're still intact. They do not degrade if there are no cells. Those surgeons were very pleased with these results because the valves were functional, not alive, but still functioning after a year. And here you see that there is a very steep gradient from tissue that is being formed, the purple part here, to the leaflets of these valves that were cell-free. But we are now diving into this. Is this because of the hemodynamics or the hinge region that is not working? So this is what's happening now in aortic valve tissue engineering. So not fully successful, but very important to report. And we are moving into this. Now, how do we get to the future? How can we do this better? Of course, we really need to fully understand how we build those tissues, and we need biologists aboard. We do very good analysis of our not so good tissues or failures, and we need to understand how patient characteristics and hemodynamics influence tissue formation. For that, we use computational modeling and iterative design process improvements. Of course, I told you already, nature and biology are very important here. It's not just the engineer that is creating those valves, and we need really a multidisciplinary approach to move into a clinical translation, as is shown here from the very nice overview of the David Kalfa group. What is important, people also try to describe for us or with us the clinical trials and pivotal trials, but the guidelines that are applicable to our procedure are actually non-existing. These are degradable materials, and we form tissue inside the body, so we are working with the regulatory agents to work on this. Now, we learn a lot from other applications. I'll do this quickly. So easy, the heart valve, of course, has a complex geometry, and we work with more easy geometries like stents, stented vessels that we implant in small animals, but also in larger animals. And we work on vascular access grafts, and their tissue formation goes very well. And the beauty of working with vascular access grafts, and this is now moving to patient studies, is that they're taken out every now and then, so we can inspect what's going on with our tissue formation in human subjects. We do repetitive puncture of those structures, tissue-engineered vessels, where the scaffold is also degrading, and they are self-repairing, so you don't see the puncture holes, etc. Now, we do all these studies with small teams, small animal studies. It's very costly. So what we think is the future to move on to is that we collect data from all these preclinical and later clinical trials in one database to have larger numbers. And we started this as an example for our vascular structures that we implanted in small animals. And here you see an overview of all the studies we did with different materials, different polymers, different biological additives. If we need one, you can decorate these materials, for instance, with SDF1 alpha, fibrin, whatever. And we compare them to pick, with using artificial intelligence, mine those databases to understand which material is better, which material is proving better in terms of biological function, hemodynamic function, etc. Once this is running, we move to valves, and I would like to invite all the people working with valves on that. I see that my time's up, so I will end with this. I asked the question, will it always be the future, to ChatGPT, and it answered very politically, yes, tissue-engineered aortic heart valves may not become the sole future, so it's good for society, but they will likely play a crucial role. Clinicians say, of course, we need to involve patient characteristics, we need to collaborate, because otherwise the field is taken over by engineers, which is not good. And finally, I would like to end with an important statement of two engineers that are working on this strategy, where they say, we are already in that future. But most of all, what I like best is the one from Bob Tancredo, who said, for pulmonary valve replacement, the future is here, and for aortic valve replacement, the future is near. And with that, I would like to thank my team and move to the discussion.
Can we have the lights up a little bit? In the back, yeah. Take the lights up a little bit. So this is open for discussion now. I think they'll have the microphones for anybody who wants to ask any questions. We'll do this for 8 to 10 minutes or so. I suppose I'll start off asking a couple questions so this is for Philippe Pibero. So tell me about whether TAVI and TAVI, what is the issue regarding patient prosthesis mismatch in that particular operation, when we know from the TVT database of about 500,000 patients that there's about a 16 to 18% primary PPM to begin with? Dr. Pibero.
Yeah, so for TAVI and TAV, PPM is not that much an issue because the stent is relatively thin, and unless we go at TAV and TAV and TAV, of course, then we're going to get a severe PPM. But otherwise, especially if we overexpand, TAV and TAV does not, lead to a much severe mismatch. Where it's more an issue, it's TAV and SAVR, then really yes. Especially we start with a small surgical valve with already pre-existing severe mismatch. The TAV and SAV cannot improve the mismatch. It will only worsen the mismatch unless you do a fracking, a stent fracturing before doing the TAV and SAV, or just after. But I mean, this procedure is controversial, but definitely TAV and TAV, not really much problem of mismatch. TAV and SAV, yes, and you should consider stent fracturing, especially in small surgical bioprosthetic valve. And it's probably why, the registry, the VIVID registry, reported higher risk of mortality following TAV and SAVR in small surgical valves, especially if there is pre-existing prosthesis patient mismatch.
A quick comment. Yeah, it depends on the valve type and the mechanism of failure. So the bovine valves, when they fail with a larger thick leaflets, and sometimes the commissural fusion happens because the pannus grows from there, and then you can have under expansion of the valve in valve. So there is going to be some issue with the type of failure, versus, at least in our experience, this has been a challenge that if the valve fails with a lot of commissural fusion, then a self-expanding supraannular valve may be the choice rather than a balloon expandable valve inside.
Overall, Samir, and Ahmed and maybe Philippe as well, what would you say the rate of valves that are surgical valves and TAVI valves that are where you can actually do a valve-in-valve procedure in today's clinical practice? What is the overall percent for coronary reasons, for hemodynamic reasons, anatomic reasons? What's the percentage where you say this is better do with open surgery? Because all these patients obviously come in with the idea that they'll never need another
10 to
open
20% is the good number to consider.
So
I agree.
So, Philippe, again, your first sentence when you first started was that the decision-making process for the first operation is critical. So how do you think about the mortality of the redo SAVR after a previous TAVR? It started off like at 18 to 20%. It's settled down at about 12 to 15% now, but it's been really steady for 3-4 years now. It's not really going down. So what are your thoughts about how that, and Samir too, as well as any clinician, what are your thoughts about that?
Yeah, I think, as I said, I think definitely the explant TAVR experience is not great. I have to say I'm not a surgeon, but I've heard that the techniques to remove the TAVR have evolved as well, and the mortality rate, the operative mortality is going down with experience, but still it's going to remain, especially with valves, transcatheter valves that have a long frame, a challenging operation. And so certainly we should try to optimize the index implant TAVR in order to avoid, the need for explant TAVR and make sure the redo TAVR is feasible. If we select the TAVR first. Otherwise, that might be an argument for considering a SAVR first.
Yeah.
So if you look at the data, and maybe you can elaborate on this, to say that the TAVR explant or patients with the TAVR who undergo other cardiac surgery, the outcomes are very similar. So my point is that it is not the operation of the TAVR valve removal, but it is the patient that is at high risk. Because if you are operating to replace another valve or bypass surgery in a TAVR patient, the mortality is very similar in both the data.
That's not appropriate. The comparator would be redo AVR.
That's right.
Okay, and not redo cardiac surgery in the setting of TAVR.
No, because the patients are very morbid. So this is what I'm trying to understand, that is it really the taking out a TAVR valve that difficult, or it is the patient that is comorbid?
I think there's an element of correctness to what you said. The initial experience was mostly patients who had endocarditis. They were the older patients in the original Partner 1 and 2 trials. But I think the numbers have come down in terms of operative risk, but they really haven't settled where a redo SAVR after SAVR, which is really about 1% or less than 1% in high volume centers, is regardless of patient characteristics. Of course, if the patient is a salvage, it's a different story, but we're talking about elective reoperations, and that number hasn't quite reached that level with SAVR after TAVR, including in high volume centers, which is still a bit of a question mark. But that brings me to the question of these studies in bicuspid valves of SAVR versus TAVR. Are we getting a little ahead of ourselves in terms of studying these things when we don't really, you mentioned it, Samir, in your presentation, all the low-risk trials, the average age of the patients was in their 70s. All these patients were tricuspid leaflets. We don't yet have any more than 5-year data. We know that the data in bicuspids is a little less good than tricuspids with TAVR, including in very highly selected bicuspid patients. Why are we doing this? They're younger patients. If the risk of stroke is a little bit higher, if we don't know what the durability is, if the rates of pacemakers are higher, PVL, why are we getting there already?
I agree with you on that account, that I think that the timing, is it right or wrong, is a good question. That's why all these trials are not yet funded, just so you know that they are not yet ready to run. And I think it is going to be like any other trial, if you try to do a superiority trial to say that surgery is better than doing a transcatheter valve, it is ethically difficult to enroll a patient. So I would be very uncomfortable enrolling a patient if I do not have an equipoise in saying that this is a better strategy or not. So this is the reason why I think a lot of leaders and people are thinking about this, that if you are going to have a non-inferiority trial, then how useful is that? That is a good question, because then it is going to be difficult to implement it in the clinical practice. And if you want to have a superiority trial with surgery as a superior method, then do we have equipoise to enroll the patient in the trial, as you rightly pointed out, because of the higher stroke rate, higher PVL, younger patient, and a very good surgical outcomes. So this is very similar to what Dr. David Adams is going to talk about, the mitral valve. But these are the similar questions that come up with the mitral valve repair versus TEER procedure.
Yeah, I can't resist. I don't know anything about the aortic valve, but I can't resist getting into this discussion. So Samir, you brought up a point we can't let go. First, which is how do you enroll a patient in a superiority trial? Like, you're involved in the MitraClip trials. How do we do that? We take MitraClip, we say, look, we know mitral valve repair is superior. That's why we designed the trial this way. Come and let me do a test on you. I don't even understand how IRBs approve this stuff. And until we all fought for it, we were going to accept moderate MR as the acceptable outcome with TEER. So that would be for another discussion, I hope, during the next 2 days. However, I think your point was really well taken, and we know it should be superior trials, and we know pacemakers in young people have mortality risk, a mortality penalty with a pacemaker with TAVR. So I think we have gotten so sloppy from where we started, and I say that as one of the national co-PIs of the core valve trial. We have inclusion criteria. We leap forward, as Ishmael said, low-risk patients, less than 5% were under the age of 70, but the guidelines went to a class 1 for age 65 and older. Why didn't we just say if you're 18 and older and enroll nobody until the age of 60, but then start doing it in 40-year-olds? Because that's what happened. And these kinds of societies that are academic and evidence-based need to get back to the evidence and start asking yourself, and it's very simple, we put it in our book, operate as you would be operated upon. If you're 60 and you had bicuspid valve disease, are you going to get a Ross or are you going to get a TAVR?
Well, we're going to have
We all know the answer to that. I know we started the debate, but Jed, the reason that's
No,
important...
that debate's going to be actually on tomorrow.
I know that's why we started the debate in this room, because Ishmael's already started it, but I was going to say specifically about the question about valve and valve. We need to get there quickly, because the average cardiologist and the average person in the community has no clue. They think everybody's a valve and valve. And so we get referred patients all the time that have a size 23 in their Joe Bavaria size. Now it's valve and valve and you're 75 or 72. It's
And you
crazy.
got a 50 millimeter gradient.
No, my point is that the guidelines should be much more clear. We all need to fight for this. It just needs to say, if you have a valve size of 21 or less, you're a surgical candidate. That's class 1. And that TAVR is palliative and it should only be considered in extreme circumstances. Quit this, everybody's going to be evaluated and we'll all have a kumbaya heart valve meeting to decide listen to the patient what they want. We need to start saying it out loud, because otherwise there's so much confusion. We get referred patients that have mitral stenosis that are 60 years old for MitraClips. We need to start being much more explicit and who's a candidate for what. And I think valve and valve is a really important topic that we could be much more explicit about.
I think the meeting is open now. Maybe just a switch of, Jordan, I had a question for you. The Atastic Watt data is very compelling and very exciting, and I think that's really the where we're aiming to get to. What are the chances that, a bit like the tissue engineered valves, you see good outcomes at 6 months and then somehow the body all the signaling just resets and you lose the effect of the drug? What's your anticipation of what's going to happen at 1 year, 2 years, 3 years? Is it a continued linear effect, or will it plateau, or do you think it will reverse?
That's a great question. And so, to which I don't have a super answer, right? I think certainly when we're looking at nitric oxide signaling in general, when you have desensitization to nitric oxide signaling, generally that occurs pretty early on, right? And sort of nitrate tolerance, if you will. And so our hope is that in these conditions where there's almost complete disabling of that signaling cascade, and then we're restoring it to some sort of physiological level that we're going to have durability. I agree with you that I think one of the challenges here is to say, well, as we're looking for these larger trials, what are the meaningful endpoints, right? Because on the one hand, you'd say, well, valve calcification, I mean, patients really don't care what their valve calcium level is, right? They care what their valve function is, they care what the left ventricular function is. And so I think, what we don't know in the field yet is if you actually stop progression of valve calcification, do you stop progression of valvular dysfunction? Do you stop progression of left ventricular dysfunction, or is there a chronic pressure overload that when it's combined with coronary vascular disease, that ultimately there's going to be a point where there's declines in left ventricular function, and then you're going to be a candidate for an intervention anyway. So I think that's kind of the holistic approach to this, to say, what are the value propositions and outcome-based recommendations that we can make for appropriate intervention and determination of efficacy in these patients. I'm not sure if that necessarily answers your question, but I do think restoration of the right pathway, I think, is going to be durable. Is my knee jerk.
One quick question, just to say that if you had a crystal ball, or if you wanted to bet on something, which one of the pathways is it? The inflammation, lipids, calcification? Which one, in your mind, would be the likely thing that we'll see in next 3 to 5 years? As a method of prolonging the valve durability?
Well, I'll preface it with saying, everybody thinks they have the most beautiful baby, right? And I'm no exception. So, to me, I would say, well, do I think that atoxaquat is going to be likely to be is kind of the lead horse on it? I do, and it's largely because it's not targeting a risk factor, right? So when we're looking at some of these other, like these lipid-based interventions for lipid lowering or lowering Lp(a) or whatnot, the question is, if you were to take a patient who has mild aortic valve stenosis, mild aortic valve calcification, and intervene there with lipid lowering and really try to tamp down that fire early on, I think that would have a reasonable shot at success. I think the question is how long is your follow-up going to have to be on that to demonstrate clinical endpoints that are meaningful? So for us, I think we intervened in patients with moderate aortic valve stenosis, so valve area between 1.1 and 1.5. So it's got a pretty good rate of progression there, and I guess I remain kind of skeptical that modulation of what would be a classical risk factor for disease initiation is going to be something that we're going to have strong evidence for in the near future.
All right, well, unfortunately, I have to take the prerogative of the moderator and cut this off because we have to get back at 11 o'clock. Thank you very much.